What is a seizure?
Overfiring of the neurons in the brain.
Very good. So that's when the neurons are overfiring. So there's a ton of electricity, right, inside the brain. What are my risks here?
Well, like head damage, like you can need to treat head on the ground.
Like injury? Okay, that's fair.
Lack of oxygen to the brain.
I could agree with that because if you're getting electrocuted in your brain, then it's like tasing your brain, right? So you could get hypoxic. Okay, and have y'all seen, or even on TV, somebody having a seizure?
Yeah.
Okay, so you know they salivate a lot. They can't control their secretions. So what would be your number one nursing diagnosis for this patient?
Ineffective breathing patterns. So
Nope.
ineffective airway.
Yes, ineffective airway clearance. You got to keep their mouth suctioned out because if you don't, then they're going to start turning blue. They're going to get hypoxic, and that's when the issue happens. Now, if they're seizing for a super long time, it is possible it could literally just fry their brain because it literally is a tasing of the brain. You with?
Yes.
Okay. So if a patient has seizures, that just means there's a lot of electrical firing. How is that different than epilepsy?
Continuous. No.
Huh.
Yes. Continuous seizure.
When? How? Like more than one, you mean?
Yeah.
Okay, so epilepsy is a disease, whereas seizures can happen. What are some reasons that people can seize where they don't have a disease, they're having seizures? Drug overdose is one. There's lots of them, you guys know. We've talked about them here a million times. Like what?
I know, like
Fever.
Fever. There's febrile seizures.
Like stimulus, like lights and stuff.
Okay, so yes, they can be stimulated by something like that. What's your keyword for sodium?
Brain.
Oh, so if they have hyponatremia, right? If they have swelling of the brain, increased ICP. So there's lots of reasons why people could seize. But if a person has increased ICP, I'm not going to say they have epilepsy because there's a cause behind their seizures. If there's no cause behind the seizures and they're recurrent, then that is the disease of epilepsy.
Okay.
Does that make sense?
Yes.
Okay. Now I want y'all to go ahead and turn it over just so you can look at because you're going to have to know how these all work. So there's two main seizure components, okay? There's either partial seizures or they're generalized. Those are the two big ones. And then there's a whole bunch underneath those, okay? So in partial seizures, it's in part of the brain. That was easy, okay? They're also called focal because they're in one focused area of the brain. And you know, every part of the brain does something different. So these seizures can look crazy and wild, and everybody's may look different, right? But they're called partial because they start in one hemisphere. They don't cross the middle of the brain. You with? And then in partial, there are two different types of partial seizures. There's simple and there's complex, okay? Simple, we call it simple because there's no change in level of consciousness. But remember, we talked about this last semester. It doesn't mean that they're awake and alert and know they're seizing, okay? It just means they're not like just on the floor totally out, right? So they may look and appear alert and oriented to you, but they don't actively know that they are having a seizure, okay? So in simple, it's really simple. There's no change in level of consciousness and it starts on one side of the brain. Easy enough? Okay. They last less than a minute and it's usually, these are wild. I think this is something spiritual, honestly, because they are sensory things. Either you smell something that's not there, you feel something that's not there, or it's something psychic where have you seen people get premonitions of something that's going to happen to you in the future, but it's actually they're actively having a seizure, but they'll just say like, you know, I won't put that on anybody here. So-and-so who's over here, don't get in your car today. And then they just come out of it. And you're like, what? What'd you just say? Wait, why don't I get in my car? What's going to happen? They can get some kind of cyclic like that. Or it may be just rhythmic where you may see just a little bit of rocking. Or some people like roll their fingers. Or they may get a really emotional outburst, which could just be a seizure. So if you've got somebody that's like sitting in a funeral and then all of a sudden they start busting out laughing, it could just be a seizure.
Wow.
And something. Oh my God. She's like, yes, I have this disease. Thank you. And then there is complex. Complex, they are absolutely not aware. Doesn't mean they're laid out on the floor. They are just absolutely unaware of what's going on. And they last more than a minute. And these are super weird too. So some people just sit and stare at you and just, that's a seizure. Okay. Automatisms, those are things that they're doing automatically, but happening over and over again. They may feel some kind of vertigo. And I wrote change in sexuality because some people will masturbate and they're saying like, oh, it's them having a seizure. I don't know about you, sir. They may wander off remember, there is a change in level of consciousness, but that doesn't mean they're in a stupor or they're comatose. It just means they may be walking around, and then all of a sudden, when the seizure's over, they look up and they're like, where am I? Okay. And they have post-ictal confusion. What does the word ictal mean?
Seizure.
That means seizure. So what's post-ictal?
After a seizure.
After a seizure. Okay. So after a seizure, they may be confused because they're looking up and like, I just lost a period of time. Okay. Do we understand these?
Yeah.
All right. And then both of those, simple and complex, can have an aura. What's an aura?
Something that happens before.
It's a warning
It's a
sign.
warning sign.
So some people will smell something, see something, feel. Some people will say like, oh, I feel like there's ants crawling underneath my skin. Oh, I'm about to have a seizure. Or they may smell coffee when there's no coffee and say, oh, that means I'm about to have a seizure. Okay. It's a warning sign that it's coming. Now that can happen in simple or complex, or people cannot have auras at all. Okay. But those can happen there. After simple and complex, it is possible that they could have Todd's paralysis. What is Todd's paralysis?
That's the after effects after the seizure.
What do the after effects of the seizure look like?
I think they'll have muscle weakness.
Muscle weakness and probably muscle pain because their muscles have just been spasming for a period of time. But Todd's paralysis, what is paralyzed? I'm sorry, on their body, what is paralyzed? Todd's paralysis. Their face, half of their face. So don't panic if you see that on, well, first of all, in clinic, but if you see that on a test question, because I would think, oh my God, they had a stroke during their seizure, right? But no, it'll cause paralysis of half their face, and it could cause paralysis of half their body. It is transient, meaning it's gonna come back. They're gonna be fine. It usually takes about 24 to 48 hours, and then that will resolve. But that could panic you, and obviously on an exam, you want to be clued in that is not a stroke. It is called Todd's paralysis. Okay. All right. There are 4 different stages of seizures. Number 1 is called the prodromal. What happens in a prodromal? For all of nursing school, what's prodromal stage?
It's like before where you kind of just feel like
Before.
achy.
Yes. So the prodromal is they kind of feel like I feel like I might have a seizure today. I don't know. Something's coming on. They can feel something is weird. What's the aural stage? That's when you have some kind of sensation. There's a warning that a seizure is coming. They see something, feel something, taste something, smell something, hear something. Maybe they'll have ringing in their ears or something like that. What is the ictal phase? That's a seizure because ictal means seizure. What would be post-ictal? After the seizure. And what is normal after a seizure for them to experience? Would they be confused? Yes. Would they have an altered level of consciousness? Yes. Might their muscles hurt like a holy hell?
Yeah.
Yes. Might they just want to sleep? Yes, because their muscles have just been through a massive marathon. You with me? Mm-hmm. What are psychogenic seizures? They're also called pseudo seizures. What does pseudo mean? Fake.
Is it from like drugs?
No, it's from some kind of mental illness. Mm-hmm. And they appear to be seizing, but when we put them on an EEG, there is no seizure activity. So I'm not saying that they're faking it. That's not what we're saying, because they may legitimately, it's very hard to fake a seizure and make it real because we know what a seizure looks like. And there are some people who do fake them. But in psychogenic seizures, there is no EEG, like there's no seizure activity on the EEG. So, it's got to be something mental where you're going through something so heavy that your brain is actually reacting by firing off. It's just not firing off hard enough to show up on an EEG. Do you understand that? Mm-hmm. Okay. All right, now let's go over to generalized. Guess what these are? Generally across the entire brain, right? Because partial was only one side. Generalized is the entire thing, okay? So they will involve both hemispheres, and they usually do not have an aura, which is scarier because these are the more serious ones. So there's no warning that it's coming. You need some coffee, Rico?
I will later.
I need some right now too. Same. I could not sleep last night and I had these most wicked dreams. Yeah. I feel like I need to do an exorcism or something weird. Because Caden came into my room too, and he's almost 14. Yes, and he couldn't sleep either. And then when he woke up this morning, I was like, "Are you okay?" And he was like, "I had weird dreams." I was like, "Me too." So we need to do something. I don't know. Yeah, I am gonna have to sage it, I think. All right. So there's a key down at the bottom. You're gonna fill these in. Okay. What does the word tonic mean? Muscle tone. Muscle tone. Okay. What does the word clonic mean?
Relax.
Jerking.
Jerking.
Mm-hmm. What does myo mean?
Muscle.
Muscle. And what does A mean?
Without.
All right. So you're going to keep those in mind as we go through the different types of seizures. All right. So let's start at the bottom. What would atonic mean?
Without muscle tone.
All right. So what does this look like? They're walking, bam, fall on the floor. Completely lose all muscle tone. That one obviously would have a very high rate of injury, right? Because you just lose. I mean, can you imagine just going completely limp and just falling on the floor? Okay. What would clonic mean? A jerking. Okay. Y'all have seen seizures like that.
Mm-hmm.
Okay. What is tonic seizure?
Like clenching?
Just, yeah, those are the ones who are tight. Y'all have probably seen these too. They're just super tight. What would myoclonic mean?
Muscle jerking?
The muscles are jerking. This is a little bit more intense than just the clonic. The clonic is smaller. Okay. What would an absent seizure mean? You go absent.
That's what you said kids have, and they're just like staring.
Yes. And you can't get their attention to something. A kid stare. They just do. Kids are weird. You know, y'all know that. Kids are crazy. And they will stare at you, like from across the room. They don't know you. But if you can't divert their attention, that's when it's considered an absent seizure. Okay. A typical one is where they stare. An atypical absent seizure is they're staring and they're blinking, but they're still there. You understand what I mean?
Mm-hmm.
Okay. We call this one a petite mal. What does petite mean in Spanish?
Small.
What about mal?
Bad.
So it's just small bad. It's not that bad. Not that bad, right? Then we go to the tonic clonic. What does tonic mean? Increased muscle tone. What does clonic mean? Jerking. So this is when they're like the thrashing ones. This is called a grand mal seizure. What does grand mean in Spanish? Big. What does mal mean? Bag. So this is a big bad seizure. Okay. You may see cyanosis. They may be completely incontinent, bite their cheek because they're going to be clamping down. They may have massive salivation. This is the most dangerous one because you could lose your airway. Do y'all understand the different types of seizures?
Yeah.
All right, now let's go into the stuff we haven't covered yet. Okay. So how are we going to diagnose seizures? What's the best way?
History?
An EEG. That's right. An EEG is an EKG of the brain, right? What does EEG stand for? Echo is the heart. So what's your brain called? If you're describing your brain. Got it. Okay. Electroencephalogram. So it is electricity, electro, and ceph means brain, and gram means take a picture. So I'm taking a picture of the electrical activity of the brain. Easy enough. Okay. But I do need to find out, are they just having seizures or do they have epilepsy? And the only way I'm going to know that is by doing a full workup on this patient with every single thing that could possibly cause seizures. So I'm going to do a full history. I'm going to do a physical exam. I'm going to do a Glasgow Coma Scale, which includes what three things? Motor response, verbal response, and eye opening. What's the max score for GCS? 15. What's the minimum score?
No, like
The lowest score you can get. 3. Okay. Below 8? Intubate. Below 8? Intubate. All right. We're going to do a family history because a lot of types of seizures may run in families. Epilepsy does. Febrile seizures do. Okay. We're going to look at their seizure history. When did it happen? What were you doing when it happened? Why am I doing a lumbar puncture? What am I trying to rule out? We're trying to rule out meningitis because meningitis can cause seizures. I'm going to draw some labs. First, I'm going to do a CBC. Why am I doing that?
You want to see if they have an infection?
Yes, infection. What about a BMP? Not BNP, BMP.
So, no. Yeah,
It is a metabolic panel. So what am I looking for?
Sodium.
I'm looking for sodium imbalances. Very good. I'm going to do a BUN and creatinine. Why am I doing that? My kidney.
Shock. No. A kidney infection?
No. What happens when you're in kidney failure and you build up in all those waste products? Where do they go? They go to the brain, right? So we want to roll that out. We're going to do a fasting glucose. Why am I doing that?
Diabetes.
Tell me more.
Maybe hypoglycemia?
It's hypoglycemia. It can cause headache, coma, seizure, death. Yes. Very good. Y'all are so easy to teach. You're so smart. All right. Treatments. when are we doing neuropharm, by the way? Is it soon or is it very far from now?
Farm.
I think it's
Let me
fine.
look.
Okay, because I need to know how much to go into detail on these medications.
Yeah, give me 1 second.
So for adult, they don't test us on meds.
Oh, they absolutely test you on meds. That's why I'm trying to see if they match up. They mostly don't, so it's kind of a pain in the butt. Yes, it would be really nice if we could do Med-Surg and then farm right after that. Wouldn't that be great? I'm pretty sure neuropharm's not till the end, which is very stupid because we're in neuro right now.
That is stupid. Okay, give me 1 second. Work. Yeah, we're doing a neurofarm the 9th week.
Okay,
Week
so
9.
let me go over the basics of anti-seizure meds. All right, well, y'all sure already know something about them. Weren't they on your lists? Seizure meds?
No.
Seizure
Yeah.
meds and statins. What
Yeah.
list was that?
Liver.
Liver. So all your seizure drugs are liver toxics. What do you automatically know? If all you have to know is it's a seizure drug, and what do you know?
It's liver toxic.
Okay, so you need to draw
Oh my gosh.
LFTs and report
Jaundice.
jaundice. Very good. And then you know the other liver toxic drugs not to give with seizure drugs, right?
Yes.
Now, y'all told me a seizure is electrical activity of the brain. So your brain's like, so what do you think anti-epileptics do?
It's gonna calm you down.
So what side effects will they have? I mean, like worse than that, like worse than drowsiness. I'm talking like good night, never wake up. Okay, so they cause severe sedation, CNS depression. So now knowing that, you know what other things you can't give with these. Like what? What else would you not give? Opiates, muscle relaxers, alcohol. You see how easy it is when you know big keywords, just big keywords. So know that all your anti-epileptics are liver toxic and they're CNS depressants, and you guys should be able to figure out all the rest. Okay. The ones, these are also very bad for women. Y'all know these are on your, many of these are on your P450 list. So a lot of them make birth control ineffective.
Okay.
But they're also, seizure drugs are teratogenic. So they get you pregnant and then they mess up your baby. You understand what I'm saying?
Yeah.
Seizure drugs are notoriously really bad for women. Most anti-seizure drugs are either category C or D, meaning they cause club foot, cleft palate, cleft lip. These are notoriously bad for women. Okay. They all cause, so look right here. So what I did was I gave you the most common seizure drugs here. Okay. The ones that are in green treat absence and myoclonic. You'll see that.
Mm-hmm.
And then you see where I wrote in black right here for all of them. These are the most common side effects for all of them.
Okay.
So you've got CNS depression, sedation, liver toxicity. All of them, for the most part, have a narrow therapeutic range. What does that mean?
That it's a very small rate.
So what do I need to do for seizure drugs?
P control.
But with these, we can't draw peak and trough because they're on them all the time. So we're going to draw serum. Yes. They all have levels. They have serum levels. Okay. So you need to make sure you do that. And they're all, for the most part, teratogenic. Except the only ones that are not, put a star next to levetiracetam. That's the only one that's not teratogenic. Okay. All right. What is status epilepticus?
Non-stop.
Seizure for more than how long? 5 minutes. Okay. What's my risk?
Loss of brain function because you don't have oxygen to the brain.
Okay. So cerebral hypoxia. Mm-hmm. They could lose their airway, right? Lots of salivation. Go on. Okay, we'll hit it in a minute. All right, so in status epilepticus, as part of your seizure precautions, when you're setting up a room for a patient coming in that you know has seizures, tell me what are seizure precautions? What would you set up the room like?
Put the padding.
Pad the side rails.
Don't stick anything in their mouth.
Don't put anything in their mouth, huh? No, you don't have to have a bed alarm, huh? You are going to time the seizure, but that's not included in seizure precaution.
Oh,
Suction and oxygen at the bedside, and it's working. The bed is in the lowest position and locked with how many side rails up?
Well,
2.
2? Okay, you wouldn't do 4.
No, you still have to do 2. 4 is always considered a restraint. Okay. I know. And in part of seizure precautions is to have lorazepam and diazepam at the bedside because those are the 2 drugs of choice for status epilepticus. This is as highly testable as the 2 drugs of choice for hepatic encephalopathy, which are lactulose and neomycin. Very good. You're going to just do just fine. All right. We put our seizure patients on the ketogenic diet. What is that? High fat, low carb. Yes. Fat is good for the brain. It builds the myelin sheaths, which surround the nerves. Okay. High
fat, low carb.
Yeah.
High fat, low carb. Yes. Moderate protein.
Okay.
The theory behind this, and this works very, very well and very highly testable. The theory behind it is they think that some seizures, especially epilepsy, is from leaky gut. Have you heard of the leaky gut theory?
I remember you told us.
Okay. So the gut is only like 1 cell thick, right? And so if there's anything that's irritating the gut, it's going to get really mad. And then little toxins can penetrate through that tiny little cell wall. Those toxins then travel up into the blood. They cross the blood-brain barrier and go into the brain. And the biggest thing that causes inflammation of the gut is gluten.
Gluten.
It's gluten. Gluten.
Okay.
Because the wheat we have now is not the wheat that our ancestors had. They had like actual wheat. Like I always want to see like, well, what did the bread look like? You know, what did it taste like? Because so many people are gluten intolerant because our wheat now is not even wheat anymore. It's all fake. It is bioengineered and it's covered in pesticides. So that massively irritates the gut, causes tiny little holes in your gut. All your poop and poisons and toxins escape through that and they go into the brain. That's why the ketogenic diet works, because it is a low to no carb, which most of your carbs come from gluten. Yes, all of us need to eat more fat, less carbs.
Should you eat less protein if you eat high protein?
No, protein's fine. Protein's really good for as long as your kidneys are fine.
Okay.
I was on keto for like 5 years and I was skinny, but then I got really hungry, so I stopped doing that. I'll go back on it at some point. Number one, it is very expensive because you have to buy mostly just meat. And now I don't tolerate dairy very well, so that's gonna be really hard to do keto without dairy because I ate the majority of dairy and it was it looked really good, but I was hungry. So the ketogenic diet works really, really well for seizures. Y'all with? Okay, turn your papers over. Let's see what you can figure out. Y'all got good common sense. Y'all are smart. Let's do it. All right. You get a call from the ER saying you are getting a patient that is coming in and they have a history of epilepsy. How are you going to set up your room?
You are going to pat the bed,
Pat the side rails.
pat the side rail.
Move anything out the way that.
All right, so keep things that keep the room clutter free. I can agree for that.
You're going to get the suction ready.
Suction and oxygen at the bedside and ready to go.
Yes.
Bed is in the lowest position and it's locked. What 2 drugs do you have at the bedside? Lorazepam and diazepam, which are the drugs of choice for status epilepticus. Good. What kind of environment are we going to set up when they come in? Low stim, so turn the lights down. Everybody cool? Okay. And you're going to put up a sign that says seizure precautions, right? Okay. And as soon as they get in there, I'm going to start an IV. How come? Yeah, what if they start seizing within 5 minutes of coming in? What happens, though, if you don't have IV access and a patient starts seizing? There's not enough time. I mean, faster.
Wouldn't you just turn them? Do you just turn them?
I mean, you can, but we got to stop it, right? Huh? Oh, no, I can't get into their bone because they're shaking too much. It is a good question and often testable. So I'm going to let y'all mull on this one. Let's say it's EMS and EMS gets called down. A patient's having a seizure. They get them into the ambulance and they're thrashing around. There's no way you can start an IV, but I have to stop this seizure. So how can I get this medicine in this patient?
Would you have to like sedate them, like give them something like an injection? Like,
But the injection's not going to work fast enough.
And you can't put anything in their mouth?
You can't put it in their mouth.
You go in their butt?
Yes.
Oh.
There is something called that would have been awkward if you didn't. I'd have been like, no, you freak. No. Yes, it is called diastat rectal. Okay. And it is in your crash cart. It should be included at all times. You'll always have it in there in case you don't have IV access and somebody is actively seizing for more than 5 minutes. Good job.
Where's that at? Is that on
Yeah, it's everything I'm talking about is on here
here?
somewhere.
I'll look for it.
I just like to talk and then sometimes it leads me other places. Okay. During a seizure. So let's say your patient is ambulating in the hallway and you're ambulating with them and they look over and say, Deborah, I think I'm about to have a seizure. What are you going to do?
Put them on the ground.
All right. So you're going to let them slide on you, slide down your leg. Didn't we do this in class? I did this with you. Okay. I was like, I remember doing this. Slide them to the ground. Try to turn them a little bit on their side. If you have a pillow to protect their head, that'd be good. What do you stick in their mouth? Oh, I tried to trick you and it did not work. We stick nothing in the mouth. They used to do a bite guard, but then they found out that was worse than anything else. Okay. And your job once they start seizing is what?
Stay with them the whole time.
Stay with them and just
Monitor.
time it. If it goes over 5 minutes, what do we do?
Lorazepam
Lorazepam or diazepam, IV push, which should be readily available for you. Yes?
Yes.
Okay. If they were in the bed and they're seizing and you're timing it, you're going to watch their color, right? Make sure they're not turning cyanotic. You should have an SpO2 on the patient, okay? If they start, what are you going to do? You're going to suction out their mouth with a, what's the mouth suction called? Yeah, I feel like y'all do.
No.
What in the hell?
No.
That was your top brain.
Yep.
It starts with a Y. Mm-hmm. Oh. It's actually, I think that there's a city in New York named this.
Yankee.
No, it's very, it's Yonker. Isn't there a city in New York named Yonker? Yeah, it's a Yonker. Yeah. Look at that. It's called a Yonkers. Yeah. But it's like Yankeur or something crazy like that. But that's the oral suction. That's what that one's called. So if somebody asks you, hey, go get me a Yonkers, then you'll be like, got you. Okay. All right. So you'll suction their mouth, make sure that their gown is loose. It's not real tight, right? And you have to stay with the patient. So if they ask you what's your priority during a seizure, your priority is to stay with the patient. Now, honestly, like you're going to time it. Okay. And that's your big job, but that's like one of those good hand washing things, you know? If the patient becomes very hypoxic, what are you going to do? And they're still seizing.
Don't you just put oxygen up to, do you follow them, put oxygen?
Yeah, like towards their face. So you're just going to point it. It's blow by oxygen, right? So y'all know the big giant tube that connects to the ambu bag?
Yeah.
You pull that off the ambu bag, it's like this big around. And you do it all the way up to 15 or however far it'll go up, and then you blow it towards their face and it's blowing. Because you can't put a nasal cannula in while they're doing like this.
Yeah.
You can't put a face mask on because what if they start puking or whatever, right? It's called blow by oxygen.
The number one precaution is to monitor the patient. Is precaution?
No, not precaution, priority.
Priority.
Your number one priority is to stay with the patient and time the seizure. Okay? All right. After the seizure, how do you position your patient? On their side in case they vomit or they're drooling or whatever, right? And then we'll give them oxygen only if they need it. Then you're going to assess their level of consciousness, which you can expect is going to be altered, right? You will assess their vital signs, make sure that we're not hypoxic, make sure that, you know, all vitals look good. You're going to assess their pupils. What would you expect to see? They should be normal. If they're not normal, then that's something wrong happened, right? So how do I document normal pupils?
Well, they're gonna perla.
Perla. Okay. Pupils equal, reactive, responsive to light. Now they may not be able to do accommodation, so it may just have to be pearl. Okay. Because they may be too much in a stupor. You're going to monitor for Todd's paralysis. What is that?
Half of the face, half of the body is paralyzed.
Half of the face and body is paralyzed. It will get better after 24 to 48 hours. Okay. So don't think it's a stroke. It's very unlikely to have a stroke during a seizure. Now they're going to say their muscles hurt. Can we give them some medicine? Yes. Do you want to give an opioid? No, because that's going to alter their level of consciousness. Then I can't tell if they're coming out of this or not. Big thing for seizures is to monitor for red urine. What does this mean? Okay, tell me about this.
I don't know. I noticed something like the muscles, lactic acid. And comes out
Okay, so when they have a massive seizure, there's two byproducts of muscle breakdown. Lactic acid and
uric acid?
Myoglobin. Okay, lactic acid goes to the liver, and the liver's supposed to deal with that, right? Myoglobin goes where? To the kidneys. Myoglobin is this big. Your glomeruli are this big. So as the myoglobin goes through, it rips through the glomeruli, and it can cause an AKI. Oh, which can end up causing kidney failure. Cool. But yes, you will see blood because it has ripped through the glomeruli. Okay, so if you see red urine, what's that whole disease process called that I just described?
Hematuria. Wait, sorry.
Okay, well, you will see hematuria. Okay, but what's the process called when they have muscle breakdown that leads to myoglobin? No, myoglobin, and the myoglobin goes to the kid. What's that whole thing called? It is a very long name. It starts with an R. Yes, very good. It's rhabdomyolysis. So rhabdo means.
Oh my gosh, I remember writing this down.
Yep.
Rhabdo.
Rhabdo in different places can mean different things. It can either mean rapid or quick. It can also have something to do with muscle. Myo means muscle. Lysis means Death. So it's death of the muscle very quickly. Okay. All right. You also need to document the seizure. What did they look like? What type of seizure was it? Did they get cyanotic? Did you have to put on blow by oxygen? Did you have to suction their mouth? You have to document everything that happened. Okay. Afterwards, remember, they're going to be tired. Flip your pages over. Thank you. Afterwards, they're going to be very, very tired. Do we let them sleep?
Yes.
Yes, we do. In a concussion, we're supposed to wake them up.
Yeah.
But after a seizure, we're like, girl, take your nap. You're going to be tired. Okay. You do monitor for confusion, but we expect it. Right? So you're going to do alert and oriented times 3, but if they're not, then I would expect that. You do want to reorient them and tell them what happened, because when they wake up, they may be in a different place than when they started. Okay? So you're going to reintroduce yourself. You just had a seizure. This is what happened. You're in the hospital. You're safe. How are you feeling? What can I help you with? Okay? And if they've had incontinence during the seizure, you want to clean that all up so that they can sleep and be comfortable. You with?
Yep.
Okay. Status epilepticus, 2 drugs of choice. Number 1, lorazepam. Number 2, diazepam, and we'll give those IV push. Those should be at the bedside if they seize for more than 5 minutes. Okay. If the patient does get really hypoxic and cyanotic, you need to call a rapid because they could code on you. When do you call rapid response? When they're almost dead. When do you call a code? When they're dead. Okay. All right. If you don't have IV access, what do you do?
Rectal.
Diastat rectal, which is diazepam rectal, basically. Okay.
So diazepam to the rectal?
Yeah, because it's diastat. So stat means quickly, and it's dia because it's diazepam. Yeah. You got it?
Yeah.
Okay. If the patient says, what can I do to prevent these in the future? What are things that you're going to tell them to do to prevent seizures? Know their triggers and probably try to avoid those, like flashing lights, things like that. Don't go to a rave. Okay. What else? What kind of diet? Go on.
So which is low carb?
Low carb, high fat, moderate protein. Tell them not to drink alcohol because that can induce seizures anyway in anybody. Okay. A lot of patients, when they have epilepsy, when they get sick, they seize every single time. They seize because it's a trigger for them, right? What type of vaccinations would you want them to get?
All of them?
Yes, but specifically, what are they going to ask for seizures? What are some ones that you think? Meningitis, probably pneumonia and flu. Those are the two, like the ones that like can cause big diseases that can make you really sick. You have to talk to them about medication compliance. A lot of people do not like to take their seizure meds because they make them so sleepy. And you cannot drive for how long after you start seizure meds?
Isn't it like 6 months?
You've got to be 6 months seizure free before you can drive. And that is awful because how do you go to work? How do you take your kids places? How do you? So a lot of times they won't take their meds because they're like, I got kids to take to school. I've got to have a job. I have to pay rent, you know?
That's terrible.
Make sure that they're doing regular meals and snacks because if their blood sugar dips, they can seize.
Yes.
Yeah? Okay. And then we're going to teach them things to relax their body. Like what? What are our big code words that they always test you on? Biofeedback, guided imagery. Yes, we're going to do all of those things. Relaxation therapy. Okay. They should always wear a med alert bracelet because if somebody just finds them laid out on the side of the road somewhere, they need to know that, hey, they had a seizure and they're not just drunk or dead. Okay. They're not supposed to swim by themselves. How come? If they have a seizure in the pool, nobody's there to help pull them out. They're supposed to let somebody know when they go take a shower or a bath, so that way somebody's looking out for them if they fall in the bathtub or if they fall asleep in the bath. Okay. There are 3 goals for our seizure patients. Number 1, we want them to be seizure free. Number 2, we want them to be free from what during the seizure? Injury. Number 3, we want them to have no what during the seizure? Other than injury. We did that one.
Things with the brain.
What's the other thing we monitor for during the seizure? That we would give blow by oxygen for. We'd look for blueness around the mouth. Okay, no hypoxia. Those are our 3 goals. So seizure free, free from injury, no hypoxia. Got it? Do we understand seizures? It's not so bad.